Good morning, everyone. My name is Dr. Yaser. I'm one of the CT1 medicine trainees in the IMT program at Conquest Hospital. Today, we'll be talking about the management of acute IBD in the context of the COVID-19 pandemic. And the objectives of this presentation is to provide an overview of generally how to manage an acute IBD presentation in the inpatient setting, and to illustrate the challenges that we face during the COVID-19 pandemic, and also to highlight some key differences in the management between Crohn's and ulcerative colitis. So why choose this topic? How big is really the problem? From a statistical point of view, up to now, we've got over 5,000 cases of COVID-positive IBD patients who were reported since the start of the pandemic, and around 860 of them were hospitalized, unfortunately, with reported deaths up to 89 cases. The data is actually as up to date as to the 2nd of March 2021. We've got 220 reported cases in the United Kingdom and over 2,000 cases in the US alone. So when it comes to management of acute ulcerative colitis, the BSG, or the British Society of Gastroenterology, they published an evidence-based guidance. The idea is we don't know. It's really unknown whether these points or such guidance is actually appropriate in the setting of the COVID pandemic. So in absence of high quality evidence-based reference, it was very important to convene a RAND appropriateness panel in order to adapt the current guidance we have to the new settings. So the PSG guidelines are still used as the reference point. All what happened is a RAND appropriateness panel was done to make sure the guidance has been optimized to deal with the current pandemic. Generally speaking, 25% of patients with ulcerative colitis will develop acute severe ulcerative colitis, and the mortality is around approximately 1%. So it's really very important to familiarize yourself on how to manage acute ulcerative colitis, especially in the context of the current pandemic. When it comes to data collections, we've got two big studies running right now: the Prepare IBD, which is a UK-based study, and the Surveillance Epidemiology of Coronavirus under Research Exclusion IPD Registry, which is shortly known as the Secure IPD. Both collect data about IBD positive patients, and this data helps us with in terms of future optimization of the guidance and while treating the patients. So let's move on to more of an interactive session and start with our first case. So you've got a 35-year-old female with a background of ulcerative colitis, which was diagnosed 5 years ago, and she has been stable on mesalazine. However, in the past 2 weeks, she has been complaining of an increased bloody diarrhea. Her bowels were opening up to 9 per day. She called her IPD nurse that started her on prednisolone, but symptoms were not improving after 3 days. So she was given advice that she needs to come to AAU for admission. At this point of presentation, you've got this lady coming to you in the AAU. What do you want to do initially? What do you want to ask about? You can write down your answers in the chat box, and we'll have a look. So let's see what we're gonna do. Okay. Some people saying they want to get the vitals, which is okay. Take a proper history. That's right, absolutely right. So what do you want to ask about in the history? Yeah, okay. And someone's saying travel history. Why do you want to ask about the travel history or to rule out infective causes? That's a good point as well. So we checked our vitals. The patient was tachycardic. She was afebrile. She had good SATs on air. Abdominal examination was unremarkable, soft non-tender, no guarding. What type of initial investigations you want to do? Okay, the admission profile, yes, user needs, lifties, that's good. Okay. Someone mentioning stool analysis, that's good as well. You want to rule out infection. Fecal calprotectin, that's quite helpful as well. Any imaging at all you want to do, guys? Chest X-ray and abdominal X-ray. Okay, that's good. So let's see what type of tests this lady had. So her fecal calprotectin came back as more than 600, which is quite high. Blood showed hemoglobin of 110, raised CRP of 65, albumin of 30. His stool cultures were actually normal. C. diff toxin was negative, and abdominal X-ray didn't show any toxic megacolon. So to summarize what you guys have discussed and shared till now, is that we need to find out initially from good history when was the inflammatory bowel disease diagnosed, what's the disease extent, when was the last colonoscopy or last, and what's the histology results, what type of treatment is this patient on, and it's very important also to screen for risk factors for infective diarrhea, like a recent travel, eating out, unwell contacts. These are very important. Because it just can mimic an acute exacerbation, and if you treat it, it would be helpful for the patient. So what do you need to assess? You need to assess the severity, and how do we do that? There is a good index for severity called True Love and Wet, which we actually use. You also need to make sure you assess the nutritional status of the patient, and if there are any sort of acute complications on presentation. This includes the anemia, the fluid depletion, megacolon, and perforation. So there are urgent. This summarizes the urgent tests that we have to do right away. And I'm going to come back to the other tests that we need to have that we have to do. But it's very important that there are urgent tests that needs to be done, and there are ongoing tests that have to be done daily while the patient is actually inpatient. Okay, so to give you an idea about True Love and Wet in the severity index, we assess the bowel movements, the blood in the stools, the pyrexia, the pulse rate, anemia, and the ESR. And then the patient is divided either mild, moderate, or severe. So it's very important to know, because to know which category is this patient, does this patient actually fit? And at this point, we're talking about the severe category. So at this point, in terms of management, what would you guys do? Increase oral prednisolone to 60 and discharge the patient because you're afraid that this patient might contract COVID? Or do you want to admit the patient and start IV antibiotics, or start IV hydrocortisone, or start infliximab? Okay, let's check the chat box. Okay, seems most of you agree on admission, which is good, and starting the patient on IV hydrocortisone, which is really the right answer. So generally speaking, those patients who get admitted, they need FlexiSec as well to be done within 24 hours, preferably within 24 hours, and this helps as well for two reasons. First of all, we need to assess the severity, and there's an index for this as well. And the second thing is actually we need to rule out CMV colitis as well. Does anyone know why do we go for FlexiSig and we don't go for colonoscopy? That's right. It's actually there's a very high chance of perforation. That's why we go down. We go with the FlexiSeg, and as you can see here, we've got the ulcerative colitis endoscopic index of severity. And so when we do the FlexiSeg, we usually assess three major areas: the bleeding, and the vascular pattern, and the presence of erosions and ulcers, whether they're superficial or deep, or whether it's just erosions. So in terms of management plan, we've all agreed that we're going to give the patient IV hydrocortisone. So the patient was started on 100 milligram QDS. The patient still reports a rectal bleed. Now, should you guys start Clexane at this point or not? Well, I see. I'm getting mixed opinions here. Some people say yes, some people say no. Well, the answer is yes, you have to start the patient on Clexane, DVT prophylaxis. That's because the IBD is a prothrombotic condition, and if you don't start the patient, you would actually be surprised on the amount of patients who come to the gastro wards without being started on Clexane for the fear of rectal bleed. You have to start your patient because it's a prothrombotic condition. After 3 days, this patient has not improved, and she's still opening her bowels 9 times per day. Her CRP rose to 100, albumin went down to 27, and hemoglobin is at 100. So now, at this point, at day 3, what would you do next? Shall you refer to surgeons, continue your steroids, start your infliximab, repeat your X-ray, repeat your stool cultures? All the answers are actually correct answers. It's very important in this scenario to actually refer the patient to surgeons to have a low threshold for any surgical complications, for a possibility of urgent colectomy. And why is that? Because we fear we fear perforations, we fear toxic megacolon, as you can see here, for example, from the X-ray. The other correct answer is that we are going to continue with our IV steroids, but we're going to start on with add-on therapy with rescue therapy. Infliximab is an anti-tumor necrosis factor medication that would be started. You would still do your abdominal, you repeat abdominal X-ray. You would check your stool cultures and re-swap again for COVID. So all these are true, are right answers. You will be surprised that around 40 to 50% of patients actually will fail the first-line therapy, which is the IV corticosteroids, and there are some sort of indications or of ways to predict the failure of corticosteroid therapy, highlighted here in this table. It's quite helpful. It gives you exactly the chance of failure based on these categories. So the patient was started on rescue therapy with infliximab, and she was given an infusion at the rate of 5 milligrams per kilo. This is usually the standard infusion. There are other courses like the accelerated infliximab, which either you go higher with a 10 milligram per kilo, or you actually minimize the duration between the courses of infusion. Hydrocortisone was still continued, and at day 7, this patient has actually improved, and she managed to open her bowels only around 4 times per day. By day 9, she has been switched to oral prednisone, and here there is something we need to highlight, is that once you switch your patient, at least monitor them for 24 hours prior to discharge, just to make sure they have a continued response, and they are not worsening as well. By day 11, this patient was actually discharged with another week 2 infusion date at the infusion unit, and IBD nurse specialist was informed for further follow-up, and this is really a very important thing to do. Always prior to discharge, make sure you arrange with the IBD nurses, because they are the backbone of how the patients will be followed up as an outpatient later on. So this is really a very important part of your management. Now, before I come to this slide, I just want to say that prior to starting a biologic, you need to screen the patients with certain investigations. And do you guys know what are we screening for? HIV, okay, that's right. Hepatitis B and C, that's good. We also want to rule out the TB. That's right. Someone saying an X-ray. That's right. So due to risk of infection, it's really very important to do a pre-biologic screen, which includes all the things we have just discussed. Just to give you a general idea about the biologics, they have an established role in medicine, and they have been used in plenty of the autoimmune diseases, including the inflammatory bowel disease. And this is a very good slide that summarizes the biologic therapy in the IBD pathway with adaptations here in the East Sussex Healthcare Trust. I'm not going to go into details, but that's just giving you like a general idea about the biologic pathway for people with Crohn's or ulcerative colitis. So to summarize what we have discussed so far, this is the guidance from the PSG prior to COVID, and shortly we'll be discussing the adaptations that have been made to this guidance. Just a quick summary: make sure at day 0 you actually know that this patient is in the severe category by fulfilling this criteria. Make sure your patient is 16 and above, because if he's younger, you will be following the pediatric guidance. Make sure you do your baseline investigations, including ruling out infective causes. Make sure you do your sigmoidoscopy. Refer the patient for sigmoidoscopy preferably within 24 hours. Rule out CMV colitis. Start your patient on IV hydrocort or methylprednisolone. Start your patient on DVT prophylaxis, and consider holding if the patient is on 5-ASAs, consider holding that. Daily review, daily assessment, and you've got your transition points at day 0, day 3, day 6. And if the patient fulfills the criteria for urgent surgical opinion, you do that for a possible colectomy. If not, then you start your rescue therapy, and which includes either infliximab or cyclosporin. Reassess, check response, and always keep a low threshold for surgical complications. If the patient actually improves, switch to oral, taper your steroids, start the patient on the thioprin, do your tests, and discharge the patient on infliximab, complete your loading dose, and commence the maintenance. All what you have to do, tick the boxes, make sure you follow the guidance, and things should be okay. Now, coming to the main thing we need to discuss here: what has really changed since the COVID pandemic in our practice? So the IBD clinics have been mostly changed to telephone IBD clinics. We've got less endoscopic assessments unless necessary. There is more use of calprotectants and small bowel MRIs. And I'm going to discuss the shielding of the patients in the later slides, and the guidance of advice in terms of shielding. Also, infusion units have been moved aside from the hospital to avoid the nosocomial infection of COVID. So, in general management, if the patient does not have any symptoms and he or she are not tested, then you just do not hold the IBD therapy. You continue as you are. Your patient is shielding or practicing social distances. just consider to reduce the corticosteroids. Now, if your patient has symptoms, has no symptoms, but he's positive for COVID, then you withhold your therapies for a minimum of 10 days. And if then no symptoms, then you restart. If your patient is positive with symptoms or with COVID pneumonia, then you have to withhold your IBD therapies and only restart when you fulfill these criteria. Now, we've got non-test-based and test-based. So you have to fulfill at least 3 days without free of fever, without the use of antibiotics, along with improvement of respiratory symptoms, along with a minimum of 10 days have passed since the first symptom. And if you're going to apply the test-based strategy as well, then you have to have, in addition to these 3 criteria, at least 2 COVID swabs done at minimum of 24 hours apart, and both are negative to restart your therapies. Now, this is actually the modified guide, the adaptations that have been done to the guidance. And just to so you can understand the case, the text highlighted with green means the same, that it's actually appropriate, and you can still continue doing it through the COVID pandemic. The red one goes for the inappropriate, which means it's advice against continuing with this, with doing it, and the yellow one goes for the uncertain, in which it's not worth nor advised against. We still don't know if it's right or not. So you still can do it, but there is no strong recommendation to go ahead with it. So we're gonna start with the first period, which is initial, starting from the admission at day 0 onward. First of all, you have to isolate all your patients. This is very important, from the general population in the hospital, put them in side rooms. You have to send swabs on admission on day 0, and those who test positive, they have to be discussed with a COVID-19 specialist. In terms of routine CT chest, it's not, it's uncertain whether you should do this or not. However, if your patient is heading towards colectomy, then you have to do a CT chest. Routine CT abdomen pelvis is not recommended, or it's deemed inappropriate. Now, when it comes to treatment, starting all the patients on IV steroids as a first-line therapy is deemed appropriate. The only exception is with those who actually test positive with symptoms or with COVID pneumonia. It's uncertain whether you should start these patients on IV steroids as a first-line therapy, or you start them on infliximab alone. What's really inappropriate is to send patient home and start them on ambulatory IV steroids, or to give them poorly bioavailable steroids. These things are inappropriate, or to start them as infliximab alone, especially with those who are negative or positive without symptoms. So what's the fuss about the steroids in general? So the secure IBD composite endpoint is that the proportion of patients who actually require admission to the ICU or require ventilation or end up in death. So from the data reported up to date till now, the medication class with the highest proportion of patients experiencing this unfavorable endpoint is that those who were on steroids. I understand we gave steroids initially as part of treatment for ARDS, the dexamethasone, but they found out that due to the immune suppression with the continued use of steroids in these patients, they are the one who experience the worst outcome. That's why there's a little bit of a debate about the steroids. So overall, other than corticosteroids, it seemed that the cornerstone therapies for IBD are actually which suppress the immune system, like the infliximab, for example, didn't result in any sort of an increase of adverse events. So just to summarize this part quickly, if your patient is negative without symptoms, go ahead with your IV steroids. Positive without symptoms, still go ahead with your IV steroids as a first-line therapy. Now, if positive with COVID pneumonia, then you still can go ahead with the steroids, but it's really uncertain whether this is it's in the uncertain category. So moving on to as I've said, patients, up to 50% of patients will fail the first line of medical therapy. So moving on to the next stage, which is at day 3 transition point, you have to repeat your swab again, and you start your patients on rescue therapy. So at this point, it's very important to know that if the patient fulfills the criteria, you have to make sure you do your surgical review for possible urgent colectomy. So what really deemed inappropriate is actually to continue the IV steroids alone. You have to combine or to add on your infliximab, and the exception here is that IV cyclosporin is deemed inappropriate, and this is due to the fact that it's actually nephrotoxic, and patients with COVID tend to have more AKIs, so it will have like a combined effect. That's why it's deemed inappropriate. And of course, you have to discuss all positive cases. If, for example, if the test is positive during the transition point at day 3, you have to discuss it with a COVID-19 specialist. When it comes to emergency colectomy, it's deemed inappropriate to use it as a second line, unless there's mandating complication like a toxic megacolon, perforation, or severe hemorrhage. So apart from these, all patients should be trialed on the rescue therapy before trying to do the colectomy or trying to go to the colectomy route. And this is actually because in COVID, as you can see here in one in one report, the mortality of operating in a COVID positive patient is up to 20%, which is very high. That's why you have to it's lower in the last. Those who actually improved, the guidance is to continue with your oral tapering of prednisolone. So we've got a standard taper, which usually happens over 6 to 8 weeks. If you want to follow the standard taper, that's fine. The recommendation goes along with the accelerated taper as well, which is between 4 and 6. Less than 4 weeks is deemed inappropriate. And the use of poorly bioavailable steroids is deemed inappropriate as well. As we've said, the use of anti-tumor necrosis factor like infliximab is deemed appropriate and safe. No adverse outcomes have been observed up to this point of time. One thing deemed inappropriate is actually the commencement of thiopren, and this is because of its side effects of pancreatitis, which might result in readmission to hospital. Its drug hypersensitivity, giving manifestations of a flu-like symptoms that mimic COVID-19, causing lymphopenia as well that mimics COVID-19, and the additional monitoring requiring face-to-face, especially when you initialize your when you commence your patient on the thiopren, so which actually increases the nosocomial infections, possibility of contracting COVID again. So that's why it's not recommended. It's inappropriate to start your patients on thiopren upon discharge. The last thing I want to discuss here, I want to mention here as well, is that thromboprophylaxis is deemed appropriate. So all patients who test positive with or without symptoms should be sent home with DVT prophylaxis. There is no consensus whether you should, for how long you should put your patients on DVT prophylaxis, but it usually ranges between 2 to 4 weeks, depending on the local guidance from the trust. So always follow your trust guidance. When it comes to shielding or social distancing, there is a very good guidance as well on the PSG website. It shows you which patients should be for shielding, which patients will have moderate risk for strict social distancing, and which one with the lowest risk that will just require the average social distancing that we practice in the common population. So what are the top messages for treating ulcerative colitis? First of all, do your basic wells. This is very important. Early surgical involvement. Always keep a low threshold for surgical complications, early endoscopic assessment, and use infliximab, whether the accelerated dose or the standard dose, depending on the severity of the disease. The difference between the accelerated and the standard is actually in the accelerated one, usually the two doses are less than 7 days apart. Or we actually start with the first dose, with a higher dose for the first one, which is like 10 milligram per kilo, with the other one within 2 weeks. And the last thing is due to the COVID-19 impact, follow the new suggested algorithms that we have just discussed right now. Due to constraints of time, I'm going to go quickly with the second case here. And it will be about an 18-year-old female, non-perianal ileocolonic Crohn's, which was diagnosed 1 year ago. She's currently on azathioprine, and she was admitted with fevers and acute abdominal pain, no diarrhea, just fever and acute abdominal pain. She was pyrexic at 38, tachycardic, with high CRP, high white cell count, and her COVID swab was negative. So what will we do? We will follow the same test as well. What I want to ask about is, at this point, would you actually start the patient with Clexane as well? Okay, it's a good thing to see that everyone actually agrees that yes, we should do that, because as I said, it's IBD, so it's a prothrombotic. You have to start your Clexane. And now the controversial question is, would you start steroids at this point? Okay, I'm getting mixed message here. I will come back to answer this question later. Okay, so some saying yes, some saying no. So let's see. So this patient was started on IV antibiotics for 5 days. She had a bowel rest with low residue diet, Modulin. She actually improved and was discharged 10 days later. And she was planned for an ileocolonic resection in 3 months' time based on her CT results. So what's really different here? What should we know? So always consider a CT to rule out an intra-abdominal abscess in Crohn's, especially with pyrexia and high fever. Crohn's is really notorious for fistulating, for fistula formation, for collections and abscess formation. So it's very important to rule it out. Do not rush to steroids unless abscess has been ruled out. And if you're really in doubt, always seek your gastro opinion. It's very important to start early on management the IV antibiotic therapy. Consider nil by mouth or low residue diet, and it's very important to involve your dietitians early. And to get same as with ulcerative colitis, early input from surgeons is quite important, especially when we suspect surgical complications. So, what are the take-home messages from this lecture? Crohn's disease, ulcerative colitis, both are actually part of the same disease spectrum, but they behave differently. So you have to adjust your management and your strategy according to this. Always refer to your BSG guidance about how to manage IBD along with the updated version for the COVID. It's very important to involve your IBD team early. So contact your SPR, your gastro SPR, your gastro consultant for referrals. Make sure on discharge to notify the IBD team, because they are the ones who are going to organize the whole outpatient scenario for this patient. So it's very important to keep them in the loop and to arrange it prior to discharge. Thank you very much for listening and for your time. And if you have any questions, just let us know in the comment box. Thank you very much. Okay.